Հայրենակիցներ, ես դոկտոր Ֆրիդա Ջորդանն եմ, ոսկրածոցի դոնորների հիմնադրամի նախագահ։ Այսօր մենք մտածեցինք, որ մեր ծրագրի մեջ ունենալ շատ կարևոր եւ հատուկ անձնավորություն, թե բժշկական իմաստով եւ թե հանգամանքային իմաստով, որովհետեւ նա ղեկավարում է Children's Hospital-ի ոսկրածոցի դոնորների փոխպատվացման կենտրոնը եւ նաեւ ինքը այնտեղի տնօրենն է եւ նաեւ այնտեղի իմունոլոգիայի բնագավառում տանում է իր research-ը։ Ուրեմն ամեն տեսանկյունից նայելով շատ կարևոր է, որ իր հետ հարցազրույց ունենայինք եւ տեղեկությունները կարողանանք ձեզ հետ կիսենք եւ նաեւ ձեր հետ կամուջ լինի եւ եթե պետք է դուք մոտենայիք այդ հիվանդանոցին, կարողանաք մոտենալ եւ տեղեկությունները ստանաք։ Այսօր իմ թաղակին եւ արժեքավոր հյուրս է դոկտոր Նինա Կապուրը, որ տարիներ է, որ մենք իրար հետ համագործակցում ենք եւ ես իմ խոսակցությունը պետք է լինի անգլերենով եւ հույսով որ դուք կարողանաք շատ մոտքից հետևեք։ I welcome you, Dr. Kapoor. I'm so glad that you managed to come. I did a long introduction in Armenian because I want our viewers to know exactly who you are, in what position, being a transplant, bone marrow transplant director program, and also a research director. It's a very responsible position and a very busy position. So I'm sure that we all appreciate your time and effort and the time that you have dedicated to come to our show. Thank you very much for coming. Before going into more details, I'd like to, in general, you describe the children's hospital programs that are dedicated in the field of hematology oncology.
Right. Thank you very much for this very kind introduction, and it's my privilege to be here and be able to share our program with the people who actually are the consumer of the services. So I want to be sure they are aware of what exactly we are able to offer in Children's Hospital. In Children's Hospital, there's a very big, actually the biggest program is the oncology program. Is under the Center for Cancer and Blood Diseases, which has two parts. One is the bone marrow transplantation program, and other is the regular hematology oncology program. And as you mentioned earlier, that yes, I'm the division head for research immunology, BMT. So we also have some research component which is going on under various other investigators. So there are many investigators. I'm actually the transplanter, so I take privilege as well as pleasure of being the physician who takes care of the patients who are undergoing transplantation. In Children's Hospital, we actually get about 1,100 new patients referred for hematology oncology program.
Every year?
Every year.
Wow.
And out of those, about 450 cases will be, which will be of oncology diseases. That means cancer of blood or cancer of brain, cancer of other areas. So those are about 150 cases will be that. And out of those, about 150 cases are every year which are diagnosed with leukemias, different types of leukemia. And the leukemia is one of the disease which is treated effectively with the transplantation, but it's important for our viewer to know that actually the regular treatment, the chemotherapy, is very effective in majority of the cases. And patients who have a very high risk diseases or who relapse after having gone through treatment, for some reason their disease is very resistant to the treatment, they are the only one who come for transplantation. Majority of cases are very well treated and actually cured of their disease with the chemotherapy. So first line treatment in majority of cases are chemotherapy.
What kind of leukemia is more prevalent in children?
So, I am sure you have heard about acute lymphoblastic leukemia,
Yes.
which is the commonest one in children, and matter of fact, it is actually the best type. If somebody is, God forbid, that's going to have
Yes.
this disease, that is the most responsive to chemotherapy. About 85% of the children who are diagnosed with this disease are cured with just with chemotherapy. It's only those other 15% of the cases who will not be doing well with the regular treatment, have to come for more aggressive treatment. That will be the transplantation.
That's excellent news.
is
What is the age range?
We actually take care of anyone from birth till 21 years of age, and occasionally when some of the patients who have been with us for all this longer period of time, we may have to make special provision for them to continue their treatment with us. And especially, I just mentioned transplant only for leukemia, but actually the transplant is done for many other diseases.
Yes.
If I may mention about that transplants are also done for variety of other type of diseases, which would be genetic diseases, like you would know sickle cell anemia,
Absolutely.
thalassemia.
Yes.
Those
Yes.
diseases are curable with the
Yes. And
this disease.
the rate of survival is much higher.
Much higher for those cases,
Yes.
because they do not have the other inherent problem which generally leukemia patient will have, whose disease sometimes tend to come back even after transplantation. So, also we also do transplantation for genetic diseases, for immune deficiency disease. You have
Yes.
known about the bubble boy disease, which is
Yes.
there is no other treatment except for the transplantation.
Yes.
And that is a fatal disease if you are not able to do the transplant. Till we are making some other progress, that gene therapy may be something in the future for us to look forward to, but for right now, transplant is the only treatment which we have available at this time. We have treatment for being advanced to rheumatological diseases and autoimmune diseases. Those are the upcoming field
Yes.
for which we will be applying this
Yes.
therapeutic modality.
Yeah. Of different type of transplants, which one is the first target that you choose for transplant?
So, since 1968, when the first successful transplant was ever taken in the world, that was done in Minnesota, the transplant from matched sibling donor, sibling who is a tissue match, not
Yes.
the blood group match, but tissue match,
Tissue match.
and that's determined by HLA typing, is the first choice for many of the diseases. For the
That's brother and sister.
Brother and sister.
Yes.
So that would be our
Yes.
first option, but only 25% of the cases will have somebody who is matched with them, who is also healthy. So that, and in average American family where there are 2.5 children, there's about 35% chance that for non-genetic diseases that we'll find a donor within the family. But for other patients, we have to find outside the family, and especially if we are talking about genetic diseases, where risk for any other child born to those two parents who are also matched and who are healthy is going to be less than 20%. So for them, we have to find alternative donor, and since 1987, since National Marrow Donor Program was established,
Yes.
that has become our biggest option for the transplantation. Now, in that group, right now, in the United States, there are over 11 million people who are volunteer. And there are about, and other alternative sources also unrelated donor cord blood, which we'll talk
Absolutely.
about.
Yes.
But, and collectively, all other registries which are working with National Marrow Donor Program, now we have access to about 18 million volunteer. But if you look at that, who are the people who have biggest chance of finding a donor is the Caucasian people of white this race,
the
and
white color,
the white color,
right,
right?
yeah,
And it's
yeah.
really is because of the number of people who are volunteering.
Yes.
So it's a game of number. More numbers you have, this is chance of like your lottery ticket.
Yes,
It
that's
becomes
right.
exactly same. That more volunteer there are of individual race, better chance there is going to be there to find a donor. And I know that today we would like to be race blind, but not in this situation, for the reason that the tissue matching which we talked about, there are certain part of a genetic material is conserved in individual race.
And we inherit from our mother and father.
Right.
Yes.
So those, and so we are saying outside the family, who would have better chance of having the same genetic makeup as me if I was the recipient of the transplant, is somebody who is within from my race, because they probably will have those same genetic
Yes,
conserved
Yeah,
in their blood. So that becomes a very important part, that for any particular race, that more people we have, more chances there will be that for any given individual for whom we do need to have a donor, that we'll have a better chance of finding it. So for a Caucasian patient, I could have about 75% chance for doesn't have a matched sibling donor, that we'll find a donor outside the family. But if I was talking about Asian Indian, there will be less than 15% chance, and primarily for the reason that there are not so many volunteers of that race in the registry. So that's a very important part.
Yeah, and that's why we established the Armenian bone marrow donor registry.
Yes. And we have been beneficiary of that registry, that there have been donors identified through the registry for patients, for children's hospital, and have received the transplantation.
Yes,
so that's
absolutely.
that has been a very fruitful effort on your part for us to be, we are the consumer of that service and of that beneficiary of that, effort, and have been able to identify the donor.
Yes, and we are complementing each other,
Exactly.
you know, and we are helping your patient, and hopefully that we can recruit more Armenian donors, so the probability of finding a match will be much higher than the current one. Dr. Kapoor, in which cases you do auto-transplant?
So the diseases where the disease does not go into bone marrow. So the stem cell which we talk about, the blood stem cell, they reside in bone marrow. And the diseases such as brain tumor, or like some of the other neuroblastoma or sarcomas, the disease is not in the bone marrow. So in those cases, marrow can be taken out and stored. It cryopreserved is like minus 180 degrees centigrade. So it's really, that freezer is deep freeze, deep freeze, and we can beforehand take the marrow out and store it, continue to treat the child, and then can go in with a very aggressive chemotherapy, which will be lethal for the bone marrow, because that is being aimed for the cancer. But in the process, the normal healthy cells are also destroyed. But at this time, we can come and rescue their bone marrow by giving the marrow which we have saved from before. And because their own marrow, it grows very nicely and have hardly any complication of the transplantation. So it's more of a rescue process which we undertake for the treatment of these solid tumors.
So you don't use it that regularly for leukemic patients?
Not regularly. There are few protocols which have been developed and which we were also part of it and had been used it. So it is more of as an effort to consolidate the treatment they are getting, aggressive treatment. So it's a step beyond that, whatever you could have given otherwise, now you are almost aiming to destroy any cells which is in the bone marrow, but you hope that you have saved some healthy marrow before, and that can be given. But those are really very selective protocol, and there used to be a purging protocol. That means you process the marrow, that you remove the malignant cells, right? But that still had not been so fruitful, and the risk of relapse of the disease was high.
Because there's some residual cells disease remain.
Right. So that's the reason. At present time, the treatment choice will be allogeneic transplant, which is from sibling. Second choice will be from the unrelated donor. And matter of fact, if you look at the unrelated donor, what we have found in our analysis, that the relapse of the disease is lower in the patient who are receiving unrelated donor transplant compared to even sibling donor transplantation, because there's a little difference between the donor and recipient, and the immune cells from the donor are able to fight off the leukemia. So that's a positive thing. Of course, probably results are still somewhat questionable, because the other complications are a little higher in unrelated donor transplant than it is in a matched sibling donor transplant.
We get usually the question of why some centers require stem cells and why some centers require bone marrow for transplantation. What is the difference? What is the major difference?
So the stem cell which we talk about, actually they are the same bone marrow stem cells,
produce cells,
right? But they are mobilized from those bone marrow spaces to come into circulation. In many cases, when we talk about the, what one should be getting or should be giving it, when we do reduce intensity, that means we are giving little less chemotherapy to a person because they cannot tolerate the real aggressive lethal doses of chemotherapy or radiation therapy. There we are relying upon the immune cells which will be in the stem cell, peripheral blood stem cell, which can go and do some of the job which we otherwise would depend upon the chemotherapy to be doing it. So, and in those cases, yes, we prefer to get peripheral blood stem cell. But more and more studies are coming up and saying that bone marrow is superior, especially for young children. We always prefer to get a bone marrow.
It's ready-made.
It's ready-made, and there are other cells which probably promote the growth of the cells. And another issue is that because there are more immune cells in peripheral blood stem cell, they can react against the body. And yes, there's a benefit of that reaction, but when it gets out of control, then it does affect the quality of life. So yes, we depending upon what particular protocol we are using. Are we giving reduced intensity conditioning regimen? Then for sure we would ask for peripheral blood stem cell. But otherwise, we per se request for the bone marrow as a source for stem cell, for which will be used for the reconstruction of the bone marrow after lethal doses of chemotherapy.
Yeah. I know, Dr. Kapoor, that the dream of every doctor like yourself is not to do the chemotherapy because that really damages the patient's physical condition. And you are doing active research in doing other kind of treatments besides chemotherapy. And I know that Children's Hospital is one of the pioneers of that research. Can you elaborate on that?
Sure. So other things which we are trying to do is find what is the best treatment where one can give that treatment to cure the disease. At present time, getting the immunoactive cells, the cells which you'll call CTL, cytolytic T cells. These are immune cells which will be one of the population which can attack the leukemia. So instead of giving chemotherapy, you say you give those immune cells and the patient can be brought into remission. That's one end. Other type of cells are some B cells which are also being reacted with the antibodies and saying can they go, they attack just those malignant cells and not other things. So these are the different type of new development which is happening in our field. Other thing is also serotherapy. There are special antibodies which will be attaching to the special markers on the malignant cells. They can go there, attach it and destroy those cells. So those are the very new avenue which are being opening up in our treatment of these patients. Of course, there are other things we are trying to find, and which was interesting things which has happened, that we found that results were not quite as good in obese patients when they were being treated for leukemia. And we have found in our experimental animals that by controlling the fat intake and reducing their diet of the fat, that medicines are working better. And they have a better result. So this is becoming a whole new movement in our management, that what should be in the diet in these patients, and who is going to have a better result, who is not going to have better result, how we can improve those results. That's another major emphasis of our research in our institution.
That's fantastic. So that relates to the diet,
right?
And also
and obesity, which has been as a right, exactly.
Yes, and cancer treatment. Or you know, so being prone to cancer.
This is a very new but very exciting avenue which is opening up for us to really work on.
Yes.
We are also working on that not every child needs to be having as aggressive treatment as, you know, at one time we thought give more and that would kill all the malignant cells. We are trying to find who are the children who require more treatment and who can be taken care of by giving less treatment, to find a special marker on their disease to see how much they need, what is their issues, which one will do better. And for the reason, as I mentioned to you earlier, that 85% of our acute lymphoblastic leukemia are doing perfectly fine just with the standard treatment, and they're surviving. When I first started doing, got into the field, if we had 15–20% children alive, 3 years down the line, we were very happy at that time. So things have evolved, but that has brought forth another issue. Now children are surviving after having been exposed to all those toxic chemotherapy. So we are very actively involved in evaluating these patients as a long-term follow-up. What exactly happened to these patients, how this treatment which we have given to cure their leukemia is affecting their heart, their lung, their kidney. Is there going to be predisposition for second malignancy because they got exposed to all this? So this is a very active program. We all feel very responsible that, you know, things which they develop at later in life are consequence of what we had done in attempt to cure the disease. So long-term follow-up and late effect evaluation and how to prevent those is in a big emphasis in our research project at Children's Hospital Los Angeles.
That's fantastic. As a physician, I'm sure you appreciate that it is so important to diagnose the patient correctly and then subscribe whatever treatment is available. Now, I know that there is nowadays there is always a talk of next generation sequencing, all this mutation detection. There is different panel for each type of leukemia. And I was at a meeting recently at the molecular pathology meeting, and I was sitting there wondering how many clinicians are using this state-of-the-art technology and knowledge in their decision. Do you do it?
Of course, and we won't be in the forefront of the thing, otherwise we're not. Just to let you know that at Children's Hospital, just to tell you our team, and we have 29 oncologists, we have 4 transplanter, we have 14 trainees. They are like, the average number of training in our program is 14. So we are making sure that new generation of people who are going to be working in the field, they all are trained and they are being taught every of these new development that they can be applying for the management of their children, patients. So yes, those technology, of course, some are still experimental, some are not.
Yes,
you heard about in ASH meeting, there was all that genome studies were talked about and predisposition for malignancy. But practical level, that what should be done, all those standard part is being utilized for the gene mutation. How we going to be talking, because the targeted treatment is becoming very important. That they are making sure that we recognize, just like the CML patient, that yes, you can do the targeted treatment, is trying to revert the fusion protein, that's what is necessary there. So all that is being looked at. The other part which we are also looking at, minimal residual disease. So that used to be one big issue, that okay, we finished 3 years of treatment, is the disease all gone? At what stage is all gone? So now we are with very sophisticated technique trying to identify those minimal residual disease to be sure that we do not back off from the treatment when disease is still there, and we can modify our treatment. If there's no residual disease is left there, we can say, okay, we need to treat some differently, we don't need to go quite aggressively. And we are also utilizing that analysis for our transplant, the patient who are coming to us who still have some minimal residual disease, what are their outcome versus the one who are free of any detectable disease, what are the outcome of those patients. So these are all new methodology which you are mentioning, that yes, those become as almost as a standard for any reputable cancer center, that we have to utilize those services.
I'm so happy that everything is done with the state-of-the-art. I was not doubting it. I'm sure that's what is happening. Otherwise, the Children's Hospital would not be the Children's Hospital of the world. And I am more excited that the hospital is in the heart of Armenian community in Hollywood. You are in the little Armenia.
Yes, of course.
And serving our patients, our little precious patients, is in your hands.
It's our privilege to take care of those patients.
Thank you so much, and we learn a lot, but unfortunately I'm running out of time, but we need to continue this conversation, which is extremely educational for me, for my audience, and for all our families there, which God forbid, if they need to come to you, they can make sure that their loved one is a trusted hand, and they can look forward to a full recovery of their disease. Thank you very much, Dr. Kapoor. My regards and love to all your staff. Because they have been very, very generous in helping us in our stem cell transplant center operation in Armenia, and to all the directors and Dr. Siegel and everybody else at the Children's Hospital. Thank you very much for coming.
Thank you very much for having me here, and thank you.
Thank you. Սիրելի հայրենակիցներ, մենք ամամանք շարունակենք այս հարցազրույցը, որովհետև տեսնում եք, որ ինչքան մեծ հարստություն կա իմացողության, փորձառության, եւ ես վստահ եմ, որ մենք պետք է շատ օգտակար լինի մեր համար, որ կարողանանք ավելի սովորենք այս հիվանդությունների մասին, որովհետեւ կարողանանք մեր երեխաներին ավելի օգտակար լինենք։ Ես ստեյշուն եմ ասում ձեզի, մինչև գալ անգամ, ստեյշուն ձեզ։